Great. Hi, everyone. Welcome to House Healthcare. It's Thursday 5th, and we are taking up a bill we've been working on for a week or two now, H766, and that's relating to prior authorization, step therapy requirements, health insurance claims, provider contracts, and collection of cost sharing amounts. And we are focusing on one section of the bill today, the collection of cost sharing amounts, or as some of us are calling it, direct billing. So we'll figure out what terminology we like as we go. So Jen's going to walk us through the language and then we'll turn to testimony.
All right, good morning. Jennifer Carby, Office of Legislative Counsel. I will put this up on the screen. We can all be looking at it together. So we are in, as the chair said, H766, which is an act relating to prior authorization and step therapy requirements, health insurance claims, provider contracts, and collection of cost sharing amounts. And it's that collection of cost sharing amounts, section 7, that we're going to be looking at. So section 7, if we're looking at the bill, starts on page 15, would add a new section in the chapter that is on kind of the provider-insurer relationship or provider-payer relationship in Title 18, Chapter 221 on healthcare administration. So this would be a new section, collection of cost sharing by health plan or other payer. We start out with some definitions. First, we have cost sharing, which means the share of costs covered by a health plan for which an insured is financially responsible. So this is the out-of-pocket side from the consumer perspective, insured perspective. Cost sharing includes deductibles, co-insurance, co-payments, and similar charges. Cost sharing does not include premiums, balance billing amounts for out-of-network providers, or the cost of non-covered healthcare services. Those are things that the insured is paying for, but is not what we mean by cost sharing. Health benefit plan is any individual or group insurance policy, any hospital or medical service corporation or health maintenance organization subscriber contract, or any other plan offered, issued, or renewed for any person in the state by a health plan or other payer, as those terms are described in another part of this subchapter. So fairly broad, but it does not include Medicaid. It's basically a major medical health insurance. And the term does not include benefit plans providing specific coverage for a specific disease or other limited benefit coverage. So this is kind of our standard disclaimer where we're talking really about major medical. And healthcare services means services for the diagnosis, prevention, treatment, cure, or relief of a physical, dental, behavioral, or mental health condition or substance use disorder, including procedures, products, devices, and medications. So a broad definition of healthcare services. So those are the definitions. And then it says a health plan or other payer shall pay a healthcare provider the full amount due for healthcare services under the terms of a health benefit plan, including any cost sharing. So the plan has to pay the provider the full amount, including the cost sharing amount. The plan shall have the sole responsibility for collecting cost sharing from an insured, and upon request of an insured, shall collect cost sharing throughout the plan year in increments defined by the health plan or other payer. So that's what the health plan shall do. Now here's what the health plan shall or other payer shall not do. Shall not withhold any amount for cost sharing from the payment to a healthcare provider. Because remember above, we said pay the healthcare provider the full amount, including cost sharing. So they cannot then withhold any cost sharing amounts from the payment to the healthcare provider. And they cannot require a healthcare provider to offer additional discounts to insureds outside the terms of the healthcare contract between the health plan or other payer and healthcare provider. Specifies that any value of a co-payment assistance coupon or similar assistance program shall be applied to an enrollee's annual cost sharing requirement and may be paid directly to the health plan or other payer on the insured's behalf. So this is kind of funds or assistance would count toward a deductible, for example, and be paid and could be paid directly to the plan or other payer. And it says that a health plan or other payer shall not cancel the health benefit plan of an insured who does not remit or otherwise pay a cost sharing amount due for services rendered. So whatever the enforcement looks like between the health plan and the insured to get that cost sharing amount paid to the insurer. It cannot include canceling the health plan. Any expenses related to implementation of this section by a health plan or other payer shall not be used as justification to increase premiums or to decrease payments to a healthcare provider. And then the last two kind of go together. A violation of this section is an unfair or deceptive act or practice in the business of insurance in violation of a provision of the insurance law. And all remedies, penalties, and authority granted to the commissioner of DFR under those statutes shall be available to the commissioner to enforce this section. And the Department of Financial Regulation may adopt rules as needed to implement and administer this section. And as far as effective dates, this one would take effect on January 1st, 2025.
All right, any questions on the language? We're gonna have people that give examples to put it into the real world, but any questions on the language, Brian?
So can you tell me the page that it starts on?
Yes, 15.
Yeah, because there was something you said that I want to read it again before I ask the question, and then if I have to ask the question, I will.
Okay, I'll do that.
Jennifer?
Yeah, page 17, line 7. Can you just go over that again?
Yes, so what it says is any expenses related to implementation of this section by a health plan or other payer shall not be used as justification to increase premiums or decrease payments to a healthcare provider. So the payer can't say it's super expensive or burdensome or nobody's paying us the cost sharing, so we have to increase premiums, or we're going to pay providers less for services because we're not getting the cost sharing amounts from the insurance. Does that make sense? As far as what the words say, whether or not you agree with it? Right.
The words make sense.
Words make sense.
Okay.
Great.
All right, Alyssa, and then Brian, and then Mari, and then Leslie.
So can you explain a little bit more, top of page 17, D, starting on line 1? Can you explain a little bit more about like what an assistance coupon might be?
I think I may defer that one to the other witnesses because I don't have personal familiarity with what the copayment assistance coupon looks like, other than I'm familiar with them sort of generally in the context of prescription drug advertising, but.
Am I okay to put you on the spot a little bit?
Who, Jen?
Yeah, Jen, not.
You can choose not to.
Because the question is in her purview, but we have H233,
Which is what?
which is the pharmacy benefit.
Oh, okay. Yep, haven't gotten to that
I
yet.
believe there's a small section in that which kind of is trying to get, you're gonna get to that? I was wondering if we could compare and contrast the language.
Yes, but not.
Not right now.
I think you did ask me for that. I apologize. I've
No, that's fine.
been pulled in a lot of directions.
Yeah, that's fine. We will get to that. Yeah. Brian.
So if I understand correctly, this would be a huge change and providers can testify about the details, but this would mean that healthcare providers will no longer have to chase after people for co-payments and deductibles, and that the insurance company would just pay us. And then we don't have to deal with that administrative burden.
So yes, what the language would do is
I didn't realize that I'm signing off.
responsibility for collecting copays from providers to payers.
That's actually revolutionary if we did that for a provider. So I want to hear what they have to say. Like, yeah,
Yes, there's a lot of money to be had. Mari, we're not gonna bring up the PBMs, but do you have another question?
You know how I love
I
that.
know you do.
So I think you already got to it, that we'll get to it later. It wasn't a policy question about H233. It was, is it by feasible, like, is someone who works in the statutes to take language from one bill? So the H233 goes into more specifics that we may want to add, and we'll talk about that later, but technically we can do that.
Absolutely, yes. You could say, oh, we like some of this language from 233, and the committee could decide to put it in here. And the only difference is I've already drafted it, so it's very easy to put it in.
So
then
the language that we're looking at right now does not include a limit on out-of-pocket maximum, like that that the cost sharing would go towards the out-of-pocket maximum. It's not included.
It talks about it applying to an enrollee's annual cost sharing requirement. We may want to clarify what is meant by that, and we can clarify it however the committee wants, but I don't, in looking at the language, I'm not sure there's a specific definition of what an annual cost sharing requirement is.
Okay,
So we should.
so that's one issue. And the other one was, it doesn't specifically call out, prescription medications, right? It's more general.
It is more general. It is really in the context of cost sharing. So yes, so how this would work in a pharmacy setting, I think we may want to explore
Okay.
what that looks like.
Thank you.
I'm sort of in Brian's world right now. I just want to confirm the understanding, and this may not be for you, but in the current world, the patient goes to see their provider, the provider collects the copay and then sends it to the insurance company. So in fact, they're doing the work of the insurance company?
My understanding is not that the provider, and providers can certainly tell you what they're doing. My understanding is more that the provider has the copayment as a portion of what they're getting paid by the insurer, and the insurer pays the rest of whatever the contracted rate is for the service. So the difference in this bill would be that the insurer would be paying 100% of the contracted rate to the provider, not 100% of the contracted rate less the copay that was supposed to be delivered specifically at the time of service by the paid, or later, but by the patient.
Huh.
So we can
So
have
instead of having, right, so instead of having the provider's rate come partially from, or payment for the services come partially from, directly from the patient and partially directly from the insurer, it would be all from the insurer, and the insurer would work with the patient to have any cost sharing amounts remitted to the insurer.
Thank you.
Oh, you done?
Yeah, I might have just been like, gesticulating.
Okay. Art, did you have a question?
Okay, sorry, I thought I said.
Brian?
I have a question. I don't think Jen can answer it, but can I ask it now so that it's out there? Maybe someone else will be able to answer it.
We wait and get when the right person comes to the table.
I don't know who that is, but okay.
Go ahead.
Well, I'll just say it, like, I'm just curious how much money would be saved in the system of care when providers aren't having to pay people to do the billing or debt collection, et cetera, and chasing after people for money. And then also like what the social benefits would be to remove that stress from the relationship between patients and providers. And maybe the providers could speak to some of that, but putting it out there, because, okay, thank you. Yep.
Okay. Anything else for Jen? Sorry.
I'm just sharing an email with everyone that might be helpful
So-
about,
If you're sharing it to everyone now, it also has to go to Claire so she can post it.
she's on the Household
Okay,
Care Committee.
great. Okay. Thank you, Jen.
Yes.
Am I here? No. Okay, Sarah. Yeah. No. Should I read? Make sure you notice this. It's fine.
He was out there, yeah. Okay.
No, that's okay. We'll start with Cindy. Thanks.
Sarah, Director of Government Relations for Blue Cross and Blue Shield of Vermont, and I did print out my notes and leave them on the kitchen counter. Starting off with a win here, but
That kind of day.
A lot of us, that kind of day.
I'm on my phone, so I'm good. I'm good. So just to speak kind of big picture to this, and I'll try and answer the first question that you kind of went through, that the patient is right now under the current system, the patient is responsible for paying the cost share to the provider, and the insurance company pays the amount that we're responsible for the provider. There's not a payment from the provider to the insurer of the cost share. That piece isn't happening.
So the payment that the co-payment or whatever a person like me pays at the counter, the provider keeps that. And then you bill the rest of it to me, the patient.
No, we don't bill the patient. The patient pays us just the premium.
The premium.
Yep.
Great.
Yep. And we pay the provider whatever the contracted amount is less the cost share.
Okay.
Yep. So, so I am not aware of this system, this proposed system being implemented anywhere at a large scale. So I haven't done a little research, not thorough, but I haven't been able to find that. I am aware of vendors who go around and offer a service to providers, because we've had a presentation from them in the past, where they say to a provider's office or a hospital, we'll collect all the cost share on your behalf, we'll take on the risk of not collecting it, but you're going to get a lower percentage of that total amount of cost share owed to you by the patient. So that's the only sort of work in this space that I am aware of on a big scale. So then to step back up, because of that, our systems, our claims processing systems are not built to do this. And the claims processing system for pharmacy also does not have any ability to collect cost share. So we'd be starting out with having to build a whole new system or an addition onto our claim system to actually implement this. So then this would apply, it's my understanding, Jen can correct me if I'm wrong, but this applies to state administered health insurance like the ACA plans and large group self-insured. I don't believe that the federal employee plan would allow us to do this for their membership, but I'm not sure. Does this not apply?
I doubt it. I don't think it applies to anybody self-insured other than governmental.
Yeah, so no large group self-insured, no MA plan.
To the extent we're able to regulate.
Right. So I think there's just a limit to how this would work. I don't believe any national insurer would do this just for Vermont. So any, of our competitors who are paying for their members here in Vermont probably wouldn't do this. So I think what you'd be effectively doing is creating two systems. The providers, there may be some savings, and there certainly would be debt collection savings by not having to collect the cost share for Blue Cross and Blue Shield of Vermont. But it wouldn't eliminate your administrative burden at all. I think
Because they would still have to do it for all the other entities.
right. So I think functionally, this would create another layer or a second separate system. So unfortunately, I don't think the goal of simplicity is achieved here. I think this actually adds complexity. As far as the cost pieces that Jen went through in the bill, there's several of them, the ones you were just talking about. So the healthcare provider cannot be asked to offer additional discount to the insurance. So if there was any savings to the provider from not having to do this administration, it wouldn't be, we couldn't try and recoup that through lower rates or anything like that. If there's savings, it's not going to be accrued to the patient. Maybe it would be accrued to the provider in the way this is set up. I was hoping Representative Cortez to just talk about the pharmacy piece in a whole separate conversation, because this is complicated. Okay. But I'm acknowledging that it's here and it's definitely an important discussion to have.
Yeah, sorry, can you go back to the comment you made before?
Sure.
So when you say, can you reference the line
I'm looking at to require a healthcare provider to offer additional discounts to the insured outside the terms of the healthcare contract between the health plan or other payer. So we can't say, oh, okay, now you don't have this administrative burden, if that was actually true. And therefore, we'd like to lower our payments to you because your costs are lower, and give that back to the patient or use it to pay for.
which I think
The intent is to not allow us to use it to pay for the new IT systems.
the intent is not to lower the provider payments. Yeah. Okay.
And then, so I'll go to E, which is the health plan or other payer shall not cancel the health plan benefit of an insured who does not remit or otherwise pay a cost sharing amount due for services rendered. Honestly, I don't know why anyone would pay the cost share if they're not, if they can keep their insurance and not be required to do it. So it looks like a lot of bad debt to me here would accrue as a result of this. That's E. And then
Can you say that again? Because I didn't totally get it. Like, why would more bad debt accrue?
So the health insurer isn't allowed to cancel the person's health insurance. Yeah, essentially. Thank you. There's no penalty for not
So
paying.
what's the current penalty for not paying?
So I think it depends on the provider, for sure.
So provider, they'll answer this, but they either take a loss or they terminate care for someone who needs it. They have this ethical decision. Yeah, okay.
Or I know hospitals have payment plans, bad debt and free care programs. That's not, small providers, I understand.
Thank you.
And then any expenses, now I'm on F, related to implementation of this section by the health plan or other payer shall not be used as justification to increase premiums or decrease payments to the healthcare provider. So that's a little bit of a repetition on the healthcare provider side. So just to be super clear, Blue Cross Blue Shield of Vermont's revenue is from premiums. We do have reserves made up entirely 100% of member premiums. So if we could not add this cost to our premiums like we do for all other IT or administrative costs, it would drain our reserves. So then I did touch on a little bit the last piece I wanted to talk about. It's really more pertains to the hospitals than the smaller providers, but bad debt and free care. So we know that hospitals have pretty extensive bad debt and free care programs to help people who can't afford their out-of-pocket costs. Because health insurance coverage in Vermont is relatively high, I think a lot of those programs are benefiting people with health insurance. Hospitals get to retain 340B revenues and have other financial benefits so that they can offer these programs. And I think this would essentially eliminate the necessity of those programs from the hospital side, but it doesn't give the payer any ability to have the resources to provide those programs. So it just seems to eliminate something that I think is beneficial to patients. So
you are against this section.
I think we see it largely as unworkable.
Okay. Questions? Alyssa? Raise your hand.
So you had said that you're not aware of, and that your claim system doesn't have the capability of this, and you're not aware of any of this being done anywhere else.
Not by a major payer. I'm not saying there couldn't be something somewhere, but by a major health insurance company, no.
Are you aware that, I mean, there are many payers that have a relationship with a third party for like an HSA, HRA, where the cost share is immediately paid to the provider, and then the insurance receives those funds out of the person's HRA directly. That, I just wanted to, you said you weren't aware of anything such as this, but this is being done. And it's on a pretty large scale. I mean, I'm not going to mention two of the largest insurance companies in the US do this.
So those are plans that are paired with HSA or HRA accounts. So they're a special subtype of health insurance that's very common, yes. And Blue Cross and Blue Shield of Vermont doesn't contract directly with a third-party payer to do that, although we recommend payers for employers to choose. And they save money on the person's behalf in an HSA or an HSA or HRA account. And then, yes, they do pay automatically, but it's not something that Blue Cross and Blue Shield of Vermont has set up.
Blue Cross and Blue Shield, I guess, I mean, I understand that this section probably isn't your favorite.
I didn't say that, yeah.
Is there any room for discussion with payers in acknowledging the administrative costs and burden of having to collect ever increasing cost share amounts, particularly with, the movement of everyone going on to sort of high deductible plans and co-pays getting bigger and bigger every year and cost shares getting bigger and bigger. Would there be room for any discussion of the payers paying providers additional administrative fees on top of their contracted amounts? And a second part question to this, which is an issue that I think about a lot and nobody else ever seems to think about, but I want to keep it on the radar, is that everyone with large cost shares now is backed up by credit card, an account. And those credit cards have fees.
The HSA.
HSAs, HRAs, FSAs are all backed up with a credit card. So increasingly, everyone is using this card and the providers are paying usually around 3% just to be able to actually collect the money that they have negotiated with the payer, the contractual amount. They're then having to pay administrative fees on top of that just to be able to receive the money that they're due. And would the payers be amenable to saying, this is not something we can do, but we recognize this, and so we're going to start paying you administrative fees for collecting off of our various plan benefit things?
Right, so any additional administrative fees that we pay to payers will go directly into premiums. So that's what will
Directly
happen.
into what?
Premiums. Yep. And I think we are faced with some of the same issues that you are. And it's the credit card company system. It's not designed by payers. You know, we have people who want to pay their premiums with their credit cards. It has the same costs for us. We are prevented by the federal Affordable Care Act laws from including an add-on fee for the actual person who wants to pay their premium with a credit card. So say you have a $300 premium, you want to pay it with your credit card, it costs us 3% too. To process that, we're prevented from saying only the people who use the credit cards can we charge that back the fee. We have to include the entire amount in your premiums. So then it spreads the cost across everyone. That's a debate we've had internally.
That's
Years. Yeah. You know, whether or not we want to allow credit card payments because people want to make them that way, and how to have the fees be paid by our entire membership. Is that really fair? So I think that I completely understand the issue that you're getting at, but I don't see having the health insurance plan pay the provider more in administrative fees solving the problem. And I do know that a lot of and our congressional delegation has some issues with the way the IRS and these high deductible health plans are working with the HSAs and the HRAs. You know, there's a lot of benefits accruing, but they're not accruing to any providers in the system for sure. So,
And I'm not sure it's a question, it's more of a statement, but you did say, why would anyone pay the insurance, their cost share, when they know that they can't be removed from the plan, that their plan can't be terminated? Why would any patient pay their provider the cost share if they can't be discharged from that provider? And considering all 14 of our hospitals are nonprofits and our FQHCs deliver, you know, massive primary care in the state, what recourse does a provider have when a patient doesn't pay their cost share?
sure. So I think it's different for small providers and large providers, and others can talk about this more than I can. But for large providers like hospitals, there are programs for bad debt and free care where they receive revenue sources to pay for those. It's not true for small offices, and I recognize that.
All right, we have Art and then Daisy and then Brian.
Yes, I just want to understand, and Laura, you can kick in with this too. Because we're talking about a small piece of the pie here, you're gonna have one system for the big piece of the pie that you serve. This would be different for the small piece of the pie. So you're gonna operate, if this were to pass, you'd operate under two systems, it sounds like. Is that what I heard you say?
I would imagine, and not only because of Blue Cross and Blue Shield of Vermont's choice, but because I don't think some of our customers would want this. And for example, we have the federal contract for federal employees' healthcare, and I don't think they would allow this to happen. So we'd be forced to have two
And
systems.
providers would be the same. They would
Yeah,
operate differently for.
Yeah. I mean, we'll let providers answer that question when
Right,
they come to the
right.
table.
Okay, just trying to understand that we're talking a small piece of the thing.
Yep.
And we're changing a fundamental change of that small piece.
Yep.
That's fine.
Daisy?
I'm struggling with how to ask this, but I hear that you're not okay with this section, and I'm also just feeling like I'd like to see you come to the table with some options that you would be okay with. My read of this is that you can't cancel the health benefit plan. You can't penalize a member, but surely you and your team can find some other ways around this. And so I just feel like there may be other options rather than us solving them for you.
sure. I don't think those are the only issues, although those are significant. I think the investment in technology is actually the biggest issue to implement this. This would be prohibitively expensive.
So let's hear from everyone else and we'll have a conversation about your, is there a path forward? Your point, is there a path forward in another way? Brian?
Yeah, I guess you said it would be prohibitively expensive. It would be helpful to get an estimate of the cost for this investment in infrastructure. And then the second part of the question I know you might not be able to answer because often actuaries are involved in this process, but how might that expense impact premiums? I would expect though that if it was infrastructure, then it wouldn't be a forever expense. So would it bump premiums up for a few years and then go away? Or would they just keep skyrocketing because of other costs, et cetera? But I'm curious what the actual cost would be. And then this question, you might be able to answer a part of it, but I don't expect you to answer all of it because I'm curious how many actual Vermonters would be impacted by this? Like how many people are on these Blue Cross Blue Shield plans and MVP plans that are from the exchange? How many people are on Medicaid or in Vermont, et cetera?
So Medicaid is not included, so it
Yeah.
would just be, and I want to say 70
to 80,000 people
Yeah.
are on those.
HPs. That's who it would impact.
And so it would just be helpful to look at who would and wouldn't be affected by this and how that creates equity issues, because et cetera. Oh, and then you mentioned that there were, how do I put this? There were services available or there were businesses out there whose sole purpose is to be like loan sharks or whatever, to go after I don't know if that's the word, or they have the baseball bat, they go. Okay, all right. They go after people for the
There
debt.
are vendors who offer the service to providers. is
Okay,
what
there's
we're-
vendors who engage in debt collection. Maybe is that what it is?
Cost sharing collection.
Cost sharing.
Cost sharing collection. There's vendors who, yes, it's not debt yet. There's vendors who profit from cost sharing collection. So there's for-profit vendors. So that to me was interesting that there's another service out there that is sort of a middle person. And I'm curious, and you may not be able to answer this yourself, but how many middle people are there doing this stuff out there?
I don't think Sarah knows this.
I don't, I was just aware that.
Yeah, but I appreciate you sharing it. Yeah, because I didn't know that. They were.
It adds more administrative complexity and another administrator in the system taking a cut of the money, so.
Melanie, and then we'll go to
Maybe I
MVP.
misunderstood, but
I felt like at one point you might have said that hospitals had systems to deal with bad debt and acute care. And we just heard yesterday, I just want to make, it's not a system that is completely working either. So I said it's not a solution to just say that the hospitals have it down. We heard yesterday from Devin Green and it's a real problem there too. So I just wanted to make sure that it's not like.
Thanks.
Yeah,
And Devin's on the list to testify.
excellent. Thank you.
Thank you, Sarah.
Thanks.
And Jordan from MVP is on Zoom. Hi, Jordan. Welcome back.
Good morning, everyone. Good to see you again. My comments are largely going to echo and reflect the same concerns that Sarah has raised. MVP
But
has.
Jordan, I'm sorry. Can I interrupt you? Can you just introduce yourself? Thank you for the record.
Oh, yes, for the record. Jordan Esty, Senior Director of Government Affairs with MVP Healthcare. Good to see everyone again this morning. So, like Blue Cross Blue Shield, MVP has significant concerns with Section 7, and we would urge your removal from the bill. Again, like the Blues, we don't have the operational capability to do this today. Would require significant IT and staffing investment. To Representative Sina's question, we haven't priced this out, but it would not be insignificant, probably millions of dollars just to operationalize, hire staff to support this. And the lead time to stand something like this up would be, fairly extensive, well over a year. And I think the feedback the most important feedback we would offer is that, our reading is that the proposal itself feels fundamentally flawed in that it prohibits our ability to use reasonable methods to recoup or account for both the added costs of the administrative spending, but also the bad debt, shifting the bad debt from providers to health plans, right? So as drafted, without that recourse for somebody not paying cost sharing amounts and little incentive to do so, as we've discussed, their coverage couldn't be terminated. Like today, if you don't pay your premium after a certain period of time, your coverage can be terminated. Somebody could not pay a cost share, and then we would have to allow them to re-enroll, the next calendar year. There's no kind of rules or penalties around that. And, I think the obvious question Sarah raised is, what would be the incentive for anyone to pay their cost share, right? And I think to Representative Black's question, I think my observation is that feels drastically different than the current system, where providers at some level can require payment for non-emergency services, or there's other opportunities to mitigate against bad debt and related administrative costs. I have a doctor's visit scheduled for tomorrow morning. I was called yesterday to pay my unpaid cost share balance prior to that visit. I had outpatient surgery last year. I had to pay a portion of my bill up front and have a credit card on file. And when I go to the pharmacy, I have to pay a cost share at the counter, or else I can't leave with the medication. So, the last piece, Sarah has mentioned the different sources of funding that are out there for larger hospitals, healthcare systems in particular, to account for bad debt, uncompensated care that they're providing in the community. Point that Sarah didn't raise, but I want to reflect on just a minute, is how this could potentially really destabilize the state-regulated commercial markets. And maybe destabilize isn't the right word, but if there's really no recourse for somebody that chooses not to pay this cost share amount, what you would likely see happen is health plans would likely start offering more of your platinum and gold type plans that really have a higher premium but a lower cost share, right? So that effectively moves most purchasers into these more expensive products, and it limits the options that are available for them, particularly employers. The options that are available in the market would be even more cost prohibitive than they are today. So small employers are already struggling to afford coverage options for their employees, and these fully insured state regulated markets are really the most price sensitive markets we have. So I would say MVP does welcome conversations about how to improve the member experience, how we can better collaborate with providers around, their experience collecting cost shares and contractual reimbursement arrangements. I know we've had a lot of internal discussions about, options related to the HSA benefit that Representative Black had raised. But that said, it's not clear how this proposal would benefit members, right? I would argue it could add to their confusion about how their benefits work and how to budget for any out-of-pocket costs. We've talked about the two-tier system. You'll have a system where what you owe out of pocket and to whom will vary depending on the source of your coverage, right? If I'm an MVP member in a state-regulated product, I won't owe any provider cost share. But if I'm an MVP member or a member of a health plan in a non-state regulated product, I will. And I certainly won't speak for the provider community, but, welcome their feedback as well. But it's unclear to us how this materially benefits providers if you're still having to maintain two separate systems, right? One for state regulated policies and one for the self-funded and captive arrangement. So, to echo Sarah's point, it seems to add more administrative complexity and cost to the current system rather than reduce it, despite the good intentions. And given the likely impact on affordability and coverage options, I think we're concerned about driving more small employers out of the state regulated markets in search of more affordable options, right? Which would exacerbate a problem that exists today. So those are kind of our remarks. Happy to answer any questions, and I can certainly submit this in writing and follow up as well.
Great, thank you for that. Brian?
So it's my understanding that currently, if a person doesn't pay their premium, they just get terminated. And I know that because things have gone wrong with credit cards, and I've been like kicked out of insurance without even knowing it. But that's the consequence I understand currently exists if you don't pay your premium.
Right.
And if a person doesn't pay their cost sharing right now, the consequences depend on the provider. Like providers like myself just incur bad debt. Others use debt collection or refuse services, et cetera, or require payment up front, like you said, before getting additional services. So those are the current consequences for non-payment of premiums or cost sharing that I understand. If the burden of cost sharing, I'm trying to be respectful with the language now too, so I'm sorry I joked about the baseball bat thing, but that's what it feels like when they come after you. So, okay, so the cost sharing, the burden of cost sharing collection, if it shifted from providers to payers, could the payers simply use debt collection as the consequence? Because you said there's nothing we can do. We can't we can't terminate them for non-payment of cost sharing. We can't, but you can only terminate for non-payment of premiums. But nothing we said doesn't allow payers to use debt collection. So couldn't you use debt collection the way providers? Couldn't the burden of debt collection shift?
Yeah, appreciate the question. I think that the biggest kind of concern conceptually in my reading of the bill is that, we can't terminate coverage. We can't negotiate savings with providers to account for the shift, and we can't otherwise account for the costs, both administrative or bad debt related in the premiums. So that is just a loss you have to take without any ability to account for that, right? So like functionally that just doesn't work.
What if we added language that said payers are allowed to use debt collection for non-payment of cost share?
So I'm gonna hold that question.
Okay.
Because I think there's a lot more concerns than just that.
Okay.
And to Daisy's point earlier, is there, is there a way to do something with the whole section? So let's hold that,
All right.
because I'd like to hear from the providers
Okay.
while we still have, and we'll.
Oh, that's true. We want to make sure.
Yeah.
Yeah, I'll save the second question for another
Okay.
time.
And are you gonna be quick?
Yes, I'm gonna be quick. So kind of moving off of that and Daisy's point of like, maybe where can we be creative? Let's say a provider, you have a contract with a provider that this provider will be paid this much for this service. They submit a claim, you approve the claim. They then have to get the cost share from the patient. Let's say they put time, effort, administrative burden into trying to collect that cost share. Is there a path where possibly that provider can go to the payer and say, we have tried to collect this cost share that you say that this patient has, and we have been unsuccessful. Will you abide by your contract by saying that we deserve to be paid this amount? Will you pay that? And then will you go after the patient?
I think, as I said, I think we're definitely open to, options to improve the experience for both the member and the provider. As far as that kind of specific concept, I'd want to have a more detailed discussion with our network folks to see what types of conversations they might be having towards that end today. And I'm happy to do that and follow up.
Great, so I put that in the kind of the category of Daisy and Brian. Okay, thank you, Jordan, very much. We appreciate your time and your testimony.
Thank you.
Jessa?
Or sorry, we're stepping out.
Okay, great,
Yes.
yes, thank you. We do have to get back to work.
Thank you.
Enjoy your day.
Test. Feel bad.
Yeah.
Good morning. Thanks very much. Jessa Barnard with the Vermont Medical Society, on behalf of physicians and PAs. And I'm also here today on behalf of the American Academy of Pediatrics, Vermont Academy of Family Physicians, and Vermont Psychiatric Association. So our primary care mental health partners. Not a surprise, strongly in support of all of the sections of the bill. And so I realized I did not send it. I have some written testimony on the bill as a whole, and this piece in specific. I mean, to us, this whole bill both reveals and addresses a lot of the administrative tasks, paperwork burden that's really been shifted to healthcare practices and providers, and why there are practice closures, why there is clinician burnout, and why basically it's so hard to recruit, especially primary care practices where a lot of this burden is falling. So Section 7, and thank you, Representative Chena. I actually do think this is pretty revolutionary, and I think it's pretty brilliant. We talked yesterday a little bit about how our healthcare system is not a system, and it's just grown up over time the way it has, and we sort of have accepted little pieces over time, changing and becoming harder to navigate. And this is one, I don't know the history of this, but how did it come about that it's the healthcare provider who collects the copay? That is the insurer plan design. That's what they have designed to keep premiums lower, granted, but also then really offload a lot of time, effort, staffing, paperwork burden, and bad debt onto healthcare providers. And it is becoming really untenable and does, again, Representative Chena, thank you for bringing this up, fragment the clinician-patient relationship. You should be in a therapeutic treatment relationship with your patient, and instead you are chasing them over $20 bills for primary care or a clinician visit. And not only that, but it's the payer who has, maybe they don't have the billing system, but they have the information about what the copay is, where they are in their health plan year, where they are in their deductible. And instead, we're sort of transmitting all this information back and forth and chasing all this paperwork and information, as opposed to the entity that's already billing the premiums, already knows what's been paid that year and what claims have been submitted from all the providers, not just this one provider who you're seeing that day. They have all that information integrated and know exactly what you owe and when you owe it and why. So to us, this makes complete intuitive sense that, in addition to your premium dollar each month, they could add on any co-insurance you owe that month. And then not put the provider in the seat of, having to send a patient to debt collection, writing off debt, or all of those other options you've talked about. So I reached out to some of our practices, and one independent primary care practice shared with me that, this is in my testimony, their patient receivables are growing all the time. In our receivables, we have amounts owed from patients that exceed 180 days that are approaching $1 million. That's since 2018. We're not optimistic for payment. And even if they wanted to work with collection agencies, they're not interested in working on it. In primary care, these amounts are a high volume of low amounts. So collection agencies conclude it's too much work for the dollar gain. And if we could get the payers to be responsible, that would certainly provide some great relief. So that's an example just from one small Vermont practice. And again, and you've already recognized this, but it is different with provider types, but smaller independent clinicians of all types, not just physicians, not just primary care, don't get the dish payments to help with bad debt. So they are just writing off, that's just coming out of their bottom line. And interestingly, the American Medical Association just this past November established a new policy supporting this exact concept, removing of physicians from the middle of cost sharing between insurers and patients, and to require insurers to collect deductibles, co-payments, and co-insurance. They have a whole report they put out in November looking at this concept and supporting it. And their findings were that the burdens fall especially on small practices in rural areas that are more intensely impacted by the challenges collecting cost sharing. So the AMA report does give a little detail. You were asking about some of the existing third-party entities that exist to help with collecting copays. They give some examples: Instamed, Flywire, Zealous, MedPilot, and those are utilized like United Healthcare and Blue Cross Blue Shield nationally. The report notes some challenges with those existing systems. So for example, forcing and requiring providers to accept them, and then deducting a percent of the payment collected as an electronic transfer fee, or otherwise reducing payments to the practice. So that's why some of the language in the bill around prohibiting, withholding, or reducing payments for the system is really important, because otherwise we just feel like it's going to be transferred from one expense to another expense. Otherwise it would just be deducted off the amount that practices are paid. So again, we strongly support this section, certainly open to tweaks or modifications to the language, but the concept is we do support. And then I will just leave for writing and happy to come back on some of the other sections of the bill, but I put it in one place since it all is one bill.
Great, Alan?
A simple question.
Yeah.
Why do we have co-pays? Why don't you just fill the insurance company?
That's the skin in the game.
I agree.
That's how the plans are created and established, but yes, that is a very good question.
We went over that
Yeah.
though, at the beginning of last session, I think.
Well, the history of why we got that?
I think we went over it.
I don't remember the
Okay, we're gonna, wait, we have limited time.
Sorry.
Art?
Yeah. Does Medicare require copay?
Medicare does have co-pays and co-insurance. This is why the MSP, why you talked about the cost sharing supports that the state could offer.
Okay,
Medicare.
here's my little 2 cents on that. Now having Medicare, for years, I always paid a copay. For years, you go to the doctor, pay a copay. Seems like, and I don't know because I didn't pay any attention to it, but when I had Medicare, since I've had Medicare, I don't remember paying a copay. Now, I don't know if they take it back and the Medicare pays the copay to the provider themselves, but I haven't paid a copay in a long time and I don't know why. They didn't ask me. I go in and
Right.
they
You just-
don't
Yeah, it could
say
be- Some folks
anything.
have supplemental
Is that enough?
plan, you may have a supplemental plan where you're also paying a premium, but that covers your co-pays or
Okay.
cost sharing.
I
maybe.
just
mean,
bring
that's
it
an
up.
option.
It's
Yeah.
not
It's on the Medicare, billing
the card.
statement that you get.
Yeah, okay.
It says copay right on it.
Okay, let's keep going. Thank you, Jessa.
Thank you.
Kevin?
Or they're hiding the bushes like the house.
You had a club.
Hi, Debbie.
Hi, Devin Green of Vermont Association of Hospitals and Health Systems. I'm just gonna co-sign right on to everything that Jess has said, and not repeat it, but I do want to also introduce the concept. So, I will admit, I was the one who, put forward some of this language, and, I have done that in years past. We looked at it, I think back in 2018. And I heard the insurers and what they had to say in terms of this will just duplicate two systems. It'll be administratively burdensome. Medicare has copays also. So what's the point of doing this? And the reason this came back up for me again was because in looking at the AHEAD model and some of the waivers available under the AHEAD model, there's a waiver to waive copays for Medicare. And so to me, and I don't know how that waiver works. They haven't given a whole lot of description about how it would work. But in my mind, I think in going forward with global budgets for hospitals, where hospitals just get paid a fixed amount, we really need to think about how can we align administrative issues as much as possible to Medicare? How can we simplify things? And I think right now in our healthcare system, we have providers that are doing the care and the money piece in terms of collecting. And then we also have our insurers that are doing, largely more the money piece, but they're also doing some care, right? They have their care managers, their care coordinators. And in doing all this, I feel like we need to separate those functions out and just make it more streamlined so that the care coordination that's currently with the payers should come over to the providers. We should be able, if we are going to take on the risk of being responsible for the health of a population, we need help with that care coordination. if the payers are going to incentivize things with how they've set up their plans, then I think they should also see the impact of their plans. I think one part of this is that they don't actually see the impact of their high deductible health plans and who can afford what and how it's impacting people. So that's why this concept really appeals to me, especially as we move into global budgets.
All right, thank you. All right.
Are you able to address the concerns that the Blue Cross had about the 340B program and the impact on hospitals?
I mean, we would love to get out of the 340B program. It is the thing that's keeping all of our hospital doors open right now. And it is highly irregular and under threat. And so, you know, this language is the ideal situation. This is what we see as like very helpful going forward. But we're willing to sit down and think about creative solutions too.
Thank you.
Any other questions for Devin? Thank you. Oh, Art.
Well, and I don't know, Devin, how much you can speak to this. On page 17, number F is the one that I've got wild put next to it, because if the payer can't prove some of the cost of having to ramp up something,
Yeah.
it seems to me that maybe the provider saves some money, but the function and the cost is moved to the payer, who now has to take that burden. It would seem that some reasonable adjustment in the premium would be warranted. And I didn't know if you thought that through or what your feelings are about that.
Yeah, again, I think the way this language was put was to try to protect both the premium payers, so the individuals, and the providers.
Right.
In this. And so that is the stance, transparently, that this language was coming from.
Okay.
I think it's a starting point. I understand the insurer's concerns.
Yeah.
And
Okay.
again, we're happy to talk about creative solutions.
Thank you.
Okay, thank you, Devin. Thanks. Bye.
Good morning still. Mike Fisher, healthcare advocate. And first off, apologies. I thought I was not needed at the moment.
We just stuck at you at the
And maybe just as well to get to hear.
Yeah.
All of us lament the craziness of our healthcare financing system. All of us, think, wow, there's a better way. And often in the interactions of just how it works today, often in the discussion of how it works today, from my perspective, from the consumer's perspective, we watch providers and payers point fingers at each other and say, it's your fault. And in my experience in this world of health policy, mostly, for the most part, health policy people tend to be in one camp or another. It's the payer's fault. Another group of people say it's the provider's fault. It's rarely that people say, oh my God, the system is doing it. And both, the system is what has created this. And everybody is at fault. And so this proposal to me feels like perfectly in this place of, no, you do it. No, you do it. I don't want that. Everybody wants more money. Everybody wants to have an increase in their rates, wants to have more money coming in to support their systems. And nobody wants the pesky little task of interacting directly with people about collecting those monies. So that's my high level response, having listened to this. I'll say that the words on the page telling payers that they have to take over this task and they can't terminate anybody for not paying for it and they can't charge anything extra for doing it and that does not feel reasonable to me, just as a standing back, that doesn't seem like a reasonable starting place. And I also would just want to spend a moment, why do we have copays? I don't know originally why we do, but I'll say from today's perspective, the out-of-pocket costs have two purposes. One of them is indeed to collect money. The whole concept of an actuarial value that the premiums are going to represent on average, 80% of the cost, 20% of the cost will be collected at the point of service when the person needs care. On average across the population, always have to say. But it is both to collect money to fund the system. It is also indeed a concept of giving, letting the member, the person, the patient know that when they get care, it costs something. And so, hey, I like to go to PT. It's nice to get the attention. It's nice to get the care. It feels good. It cost me $75 a pop. That's going to put a check on me about whether I really want to do it. Yeah. And while, and I'll just say, when we were sitting at the table across the hall and talking about a government financed healthcare system, there was discussions. I mean, there was the details were not in any way baked, but there was a recognition. Hey, we're going to still want to have some out-of-pocket costs to ride along with this, and that we would use the dial in a very different way around clinical need than necessarily collection of money. So all of that is to say, I get the reason for this proposal. I get it. It calls the question, this system stinks. I'm not sure that, I said already, I think the words on the page are problematic. It doesn't feel on a basic level fair. And it is a wholesale change and not an easy change. And so, I'm not sure I've landed where I've landed. That's my high level discussion about it. Happy to answer questions.
Right.
I think it's helpful hearing your perspective because you also have experience, not just as the healthcare advocate, so you understand the history a bit. And I'm curious what your thoughts are about, instead of, because you said your concern was that this proposal pits one piece of a system against another, but you didn't say this, but we're all cogs in a machine. We're all part, you said we're all guilty. I don't know if I'd say I'm guilty, but I feel like a cog in a machine, so we're all cogs in this machine. At this point, we're trying to change, we're pitting the cogs against the machine. Might there be a different approach? For example, what if it was just copays and no deductibles, or something easier, you come in and you get it and it's a copay. It's not that the provider is trying to track where a person's at and what they owe and which I think we heard from the medical society. So I guess what your thoughts are about instead of this, and if you don't have that today, but instead of this, what might work better in the system ultimately too for the patient, since I think that's your perspective now. It's how, what might work, what might be the easiest way to control the cost of care by showing people it costs something, but doing it in a way that's accessible, that's smooth, and that eliminates burden. I think that's the question. If you have any ideas now or at all.
I'll just say that my head went to a similar place, sort of making a distinction between deductibles and copays. And I think I was going in the opposite direction. That copays, sort of the concept of copay is what you give at the time of service. And the deductible has a sort of meaning to me, but I guess I'm happy to engage in a conversation about whether, what pieces of this, or is there a version of this that could become reasonable? But I also, and I also want to recognize, hey, we do have, as crazy as it is, a system of managing bad debt and free care for the hospitals. And we are aware of, to the questions earlier, We're aware of providers who terminate patients for very low numbers. It's not, so, you know, the provider does have a mechanism of collecting the money. And further, I always want to tell the story. My experience is that people love their providers. They want their providers to be whole. They want to pay their providers. They care about, you know, I got good care. I want to pay my provider. And so, you know, the risk of our current system, we all know it, is that people end up not going for care because they owe money.
All right, well, one last question, Topper.
It's not a question.
Okay.
It's an answer. Because Mike brought up across the hall when we were working on this. I was on the very first healthcare committee. Now, one thing that we pushed for all the time was the term ability to pay. It was based on a person's income. And to me, I think we should go back to that. As a matter of fact, in terms of the hospitals, I think we should go back and look at H304 that dealt with the hospitals all by itself. And the author of that bill.
How do you remember that?
Your little time.
And to me, that was the best way to go.
Yeah, I mean,
Because people who can't pay, based on a certain percentage of their income, don't pay. People who can pay, as you go up the line, it was a sliding scale.
you know, that I referenced earlier, $75 copay. That means something entirely different to me than to somebody else. Entirely different, prohibitive for some people, and it's manageable for me. So yeah, imagine copays. I mean, so here we are fantasizing about an entirely different financing system. Imagine copays that were based on ability to pay.
Thank you, Mike. We'll be back to this conversation.
Yeah.
So we're back at 1:15. We're continuing on 766 and we're going back to